The standard treatment of stones bigger than 2 cm is percutaneous nephrolithotomy. Classically, this intervention requires a first installation in the lithotomy position to place a ureteral catheter for retrograde pyelography, followed by a second installation in the prone position for the percutaneous surgery. With the upcoming use of flexible instruments, a unique installation in the supine position has recently been proposed. The patient is positioned in dorsal decubitus, the leg at the side of the stone in extension, the other leg in flexion, to allow retrograde access to the urinary tract. The lumbar region is lifted 20 degrees with 2 enrolled sheets. One of them is placed under the hip and the other under the shoulder. We can also use a pneumatic patient positioner. It consists of a fully adjustable cushion and an uninflated tap section which anchors the positioner in place and prevents its lateral displacement. The inflation is performed by pumping with a rubber bulb. By obese patients, it can be helpful to pull the adipose abdominal mass toward the side opposite to the stone. For this, we can use elastoplast adhesive bandage. After this maneuver, the procedure is as simple as in patients with normal body stature. The punction will be done at the posterior axillary line, which is indicated with a marker. With the patient in Valdivia Galdacao position, the needle is roughly in the horizontal plane. The X-ray beam is perpendicular when the C-arm is in vertical position. When compared to standard prone position, the distance between the posterior axillary line and the colon is significantly increased. Thereby, the risk of intestinal injury is considerably diminished, and the safety of the procedure is improved. Trapping and draping is done during a single step for both operative sites. This installation allows for 2 surgeons to work together and rationalize the distribution of specific tasks during the surgery. The technical equipment is placed as follows. The radioscopy monitor is placed at the head side of the patient, ipsilateral to the stone. The C-arm is placed in front of the first surgeon. The ultrasound device is placed at the foot side of the patient, at the side of the stone. The video tower is placed in front of the first surgeon. Ideally, 2 video sources are connected. 2 back tables are prepared, one for the retrograde access, another one for the percutaneous surgery. The assistant performs the cystoscopy and places the ureteral catheter, while the first surgeon prepares the renal punction. Methylene blue dyed contrast material can be injected as required at any time during the whole procedure. As for the standard technique, the renal punction is done under ultrasound control to assure the absence of bowels in its trajectory. In certain cases, the punction is easier and more precise under fluoroscopic control. In difficult cases, especially in patients with poor echogenicity, a purely fluoroscopic puncturing method can be used. A small surgical clamp is placed on the anterior abdominal wall to facilitate spatial orientation. The tip of the clamp is in the projection of the targeted calyx. The needle enters the posterior axillary line in the horizontal plane. Its axis follows the axis of the calycial infundibulum. If no urine appears when the needle tip projects on the calyx, this means that the needle is anterior or posterior to the calyx. In order to estimate the needle position relative to the calyx, the C-arm is tilted 30 degrees cephalad. If on the fluoroscopic monitor the needle tip moves in the opposite direction than the tip of the clamp, this means that the needle is posterior to the calyx. The needle is pulled back slightly and reinserted with adequate modification of its vertical inclination, but respecting the axis of the targeted calyx. Here we demonstrate the axis creation in a left stack or stone. In this example, When the C-arm is tilted, the needle moves cephalad, while the clamp moves caudally, meaning that the needle is behind the targeted calyx. The intracalical position of the needle is verified by the appearance of methylene blue. For creating and dilating the access, we prefer using a safety guide wire enrolled in the renal cavities and a working guide wire descending to the ureter. Therefore, our first dilation is done with a nephrostomy dilator with a pillable access sheath. This sheath is advanced up to the renal pelvis, and a second guide wire is placed. The safety guide wire is attached to the skin with a sticker. The dilator is again advanced over the working guide wire. The progressive retraction of the hollow metallic obturator of the nephrostomy allows to modify its curve and orient the working guide wire. When the working guide wire is advanced in the ureter, the dilatation is done by the standard technique. In this patient, we use the balloon dilatator. The amplet sheath is placed in the cavities and the nephroscopy begins. The horizontal or slightly inclining position of the amplets facilitates the evacuation of stone fragments. The stone fragmentation is done by using the usual instruments. Here we use the little glass master. At the end of the intervention, apart from a nephrostomy, a double G stent can be placed without modifying the position of the patient. The double renal access simplifies the installation of the patient, permits in the majority to diminish the operative time, and improves the ergonomy of the surgeon. However, there are some limitations. First, in absence of abdominal compression, the kidney is more mobile than in prone position, which occasionally makes the dilatation of the trajectory more difficult, especially at the level of the kidney capsule. In that situation, we systematically use the balloon dilatator. Secondly, when the patient is inclined 20 degrees, the ureter and the renal pelvis project over the vertebral column. This can diminish the visibility of the stone. It is possible to change the inclination of the C-arm, but in that case, the metallic border of the table interferes with the image. Thirdly, the access to the upper or anterior calyx can be more difficult or impossible with the rigid nephroscope. In certain cases, the table or the patient's hip may restrict the mobility of the nephroscope. This occurs only with older nephroscopes, in which the cranked or 45-degree offset optic and the light cable are on the opposite side of the shaft. Presently, all major manufacturers propose new generation nephroscopes that are more ergonomic and on which the light cable, the optical, and the irrigation connector are on the same side. Another possibility to overcome this problem is the use of flexible instruments. The flexible cystoscope allows to inspect all renal calyces. Stones with difficult access can be displaced with a Dormier basket or fragmented with a laser. If a ureteral stone is associated, it can be reached with antegrade or retrograde access. The fragment situated in the upper calyx can be extracted with a Dormier basket through the amplet sheath. Another example of endoscopic combined renal surgery is illustrated on a patient with a huge ureteral and a lower pole stone. While one of the surgeons begins standard semi-rigid ureteroscopy, the other creates the nephrostomy tract. Fragmentation of the stone is started with holmium laser through the ureteroscope. Then a flexible nephroscope is inserted through the amplets, allowing access to the stone anterogradely. The presence of the amplets helps to increase significantly the flow rate of the irrigation fluid through the ureteroscope and considerably improves visibility. Both video cameras are connected to a wide screen, allowing optimal coordination of the two surgeons. The fragmented ureteral stone is flushed into the renal cavity. Small fragments spontaneously drain through the amplets because of its sloping trajectory and the washout effect of the irrigation. Bigger fragments can be removed in the usual way with nephroscopic forceps. In conclusion, supine position for percutaneous nephrolithotomy is here to stay and means a significant progress in stone surgery. It is likely that this position will become routine, but the precise indications still have to be determined.